So good morning, everyone. I have the pleasure of introducing Dr. Kendall Beck, who's one of our esteemed IBDologists here at UCSF and also specializes in short bowel syndrome. Um, in my experiences working with her, I've always been very inspired by her clinical acumen, patient-centeredness, and also the appreciation her patients always express for her on the wards and in the outpatient setting. She earned her medical degree from McGovern Medical School at the University of Texas Health Science Center at Houston, and then completed a residency in internal medicine and fellowship in gastroenterology here at UCSF. She's now an associate clinical professor of gastroenterology and focuses on inflammatory bowel disease, short bowel syndrome, as I mentioned, and also general GI issues. She's also interested in the care of the older population with IBD. We are all looking forward to her talk on managing IBD in older and frail adults. So I'll turn it over to her.
All right, thanks, Donna. Good morning, everybody. I'm happy to be here to talk to you about managing IBD in the older and frail adults today. So these are my disclosures. So today our objective is to identify special considerations for older and frail adults when making an IBD diagnosis, discussing prognosis with the patient, creating a treatment plan, considering surgery, and monitoring for nutrition issues and healthcare maintenance. So why should we consider age and frailty when managing a patient with IBD? This is a case of an elderly, frail woman with Crohn's disease. She was diagnosed in 1985 and is status post proctocolectomy with end ileostomy, as her original diagnosis was UC. This was complicated by lysis of adhesions along with multiple SBOs. When I met her, she was biologic naive and had not been on any treatment for many years since her surgery. She was admitted with diarrhea and had acute kidney injury, AFib with RVR, and a partial SBO in the setting of administering multiple antidiarrheal agents for high ostomy output. She was unfortunately unable to quantify her ostomy output, however. Her past medical history included cognitive decline, CKD, and atrial fib. Her social history was significant for her spouse, who was her primary caretaker, who was a retired physician himself, and he also had aortic stenosis and was in pretty significant need of an aortic valve replacement. Additionally, she had had a positive PPD in the past. Her last scope was her last two scopes, one in 2010 was normal, and in 2011, she had a small ulcer in the ileum, but had not had any follow-up since then. So CT imaging showed dilation of her small bowel up to 6 centimeters, and a fecal calprotectin on her ileostomy effluent was elevated to 450. Ileoscopy was unfortunately delayed by almost a year due to her spouse not being able to bring her in for her procedure because, again, of his own health problems of aortic stenosis and requiring surgery. When ileoscopy was performed, unfortunately, she had developed erythema and ulcers, which were concerning for active Crohn's inflammation, and biopsies were consistent with chronic active ileitis. Entyvio was recommended for multiple reasons, including side effect profile, and it was not clear that they would be able to manage at-home injections. Her spouse unfortunately declined medication despite extensive counseling due to his sort of disbelief that the Crohn's had come back. Unfortunately, she continued to have significant ostomy output, and this was managed by parenteral fluids, and she eventually became functionally frail and became wheelchair-bound. 1 year later, she developed altered mental status and urinary, or actually fecal incontinence, and ended up being admitted and found an intra-abdominal abscess with enterovaginal fistula. She subsequently also had developed a reduced ejection fraction and moderate aortic stenosis. We did initiate antibiotics at that time, of course, and Stelara was initiated. However, despite that, she had a very poor outcome. So her case really demonstrates multiple challenges with managing older and frail adults with IBD, including the potential for cognitive and functional decline, multiple medical comorbidities in herself as well as her primary caretaker, which affected her disease course. And this unfortunately led to a poor outcome, possibly due to delays in care. So these are just some fast facts about older adult patients with IBD. So first off, what do we mean by older adult? It really depends who you're talking to and what study you're reading, but most people consider an older adult patient with IBD as age greater than 55 to 65. About 1 out of 160 patients in this age group are affected by IBD. About 15% of new IBD diagnoses will be made in this age group. And greater than 1 out of 3 IBD patients will be in this age group in the next decade. There's not been found to be and have any difference in mortality for UC patients who are older. However, mortality from Crohn's disease is higher in the older adult population with Crohn's than with the younger population. Unfortunately, despite this, only a small portion of clinical trial subjects are made up of this older age group, approximately 5%, and they make up a very small portion of pharmacovigilance data as well. Therefore, clinical data is really based on observational studies, indirect evidence, and expert opinion. So specifically, we can break in the older adult age group to all patients who are older with IBD, whether they were diagnosed at an older age or aged into that group after being diagnosed at a younger age. And then those who were have, quote, new onset IBD in the older population. So those that are diagnosed with IBD when they're already in that older age group. So in that group of patients, patients are more likely to be diagnosed with left-sided ulcerative colitis, or in the case of Crohn's disease, they're more likely diagnosed with isolated colonic Crohn's. Patients who have older onset IBD are more likely to require surgery for ulcerative colitis. However, there's a similar need for surgery for Crohn's disease. I would say that disease-related adverse effects are likely underappreciated for older IBD patients, as they do experience an increased rate of hospitalization and neoplasm diagnosis compared to younger patients with IBD. Despite that, older onset adults are more likely to be treated with long-term steroids and undertreated with steroid-sparing agents such as biologics and immunomodulators. And this is the case for Crohn's and UC. So when we're thinking about treatment for our older adult patients with Crohn's disease, it is really most important to consider specific disease characteristics when prognosticating and determining management strategies, rather than just simply age or trends. So what is frailty? Many patients who are not older may present with similar factors as the ones described in our case presentation. This is why age is considered an imperfect factor in determining prognosis and susceptibility to treatment, as well as disease-related complications. The frailty construct may provide a more useful information when we are curious about a patient's true prognosis and trying to calculate risk when deciding on a treatment course. Unfortunately, there's no truly agreed upon definition of frailty in the literature. However, there are 2 models that are useful for defining the condition. So phenotypic frailty, also called physical frailty, is defined as a medical syndrome of multiple causes characterized by diminished strength, endurance, and physiologic reserve or function. This type of frailty does increase the risk of dependency and death in our patients. To diagnose this type of frailty, phenotypic frailty, you must have at least 3 out of 5 characteristics of involuntary weight loss, weakness, fatigue, reduced physical activity, and reduced walking speed. This type of frailty is considered preventable and reversible by intervention. Conversely, there is the accumulation of deficits model of frailty, which assumes that it's the number and not the nature of health problems that are accumulated that contribute to the increased state of frailty. And therefore, this model is not considered reversible by intervention. Both models are predictive of adverse health outcomes in a variety of medical conditions, but likely identify a different subset of patients. Overall, though, you can think of frailty as a syndrome of a reduction of biologic and functional reserve that is predictive of adverse health outcomes. So how can I measure frailty in my patient? Frailty measurements are imperfect, and they have been created for use in multiple settings. None were specifically created for or validated in IBD patients at this time. There are multiple different assessments. The comprehensive geriatric assessment is considered the gold standard for measuring frailty. However, it's cumbersome to use in clinical practice. The hospital frailty risk score relies on diagnostic codes for determining one's risk for frailty and is technically created for hospitalized patients, though it is a common score to use in clinical research, and several studies apply it to the ambulatory setting as well. Sarcopenia is a condition which is technically separate from frailty, but is typically a component of frailty. There are also multiple different modalities to measure sarcopenia, some by imaging, some by biometric testing, and also some by functional testing. So the clinical frailty score and the geriatric AIDS score are probably the easiest to apply in the ambulatory setting. The clinical frailty score relies on measurements of mobility, activity levels, control of medical problems, dependence on ADLs, and risk of mortality for our patients. And the geriatric AIDS score relies on measures of age, food intake, weight loss, BMI, number of medications, as well as neuropsychiatric conditions. So it's probably not surprising to learn that findings in clinical studies do differ depending on the setting and the assessment used. And so how does frailty impact my IBD patient? So 12% of IBD patients are considered high risk for frailty versus non-IBD patients. However, there is quite a range in the literature. Factors that contribute to the risk of frailty in our IBD patients include age, probably being female, number of medical comorbidities, and polypharmacy. Having Crohn's disease and having more severe disease are also associated with an increased risk of frailty. Disease activity leads to several major factors associated with frailty, including loss of skeletal muscle, malnutrition, polypharmacy, and mood and cognitive disturbance. Frail IBD patients do experience more hospitalizations, as well as mortality and readmissions in hospitalized patients. Additionally, studies have shown that infections are increased in frail IBD patients who are treated with anti-TNF and immune modulator medications. Frail patients also experience a lower quality of life. There is so far no known association of risk of frailty that is caused by the medications that we use to treat our patients, specifically biologics or immune modulators. Notably, however, treating disease activity has been shown in frail and older adult patients to reduce the risk of frailty post-treatment, especially in those patients that had a higher baseline level of frailty. So this is encouraging for our patients when we're discussing treatment. So we can move on to the diagnosis and management of IBD in our older patients. So we're thankful to have the first expert review published a few years ago detailing important factors to consider when diagnosing and managing the older patient with IBD. It's important to note that while the incidence of IBD is increasing in older adults, they are still more likely to have an alternative diagnosis. So, such as colorectal cancer, ischemic colitis, NSAID-induced pathology, radiation, enterocolitis, microscopic colitis, infectious colitis, and even rectal ulcer syndrome. So these conditions should be ruled out when someone is presenting with IBD symptoms. So this would be over here on the left of this chart. You have a low suspicion for IBD, but a high suspicion for alternate causes. That's the first step. Evaluate for other causes and being judicious with using colonoscopy in these patients, as they do have a higher risk of complications from colonoscopy. So using non-invasive testing first, imaging and stool testing. If you have a moderate to high suspicion for IBD or suspicion for microscopic colitis, again, we will often still use non-invasive testing initially, but if that confirms our suspicion, then we would move on to colonoscopy with biopsy, of course. Treating older patients certainly requires a multidisciplinary approach. They are at higher risk of polypharmacy, more medical comorbidities, depression and mental health disorders, as well as physical and cognitive decline, which can be associated with treatment-related complications. And also just to remember that they may need special accommodations to ensure access and adherence to care, whether that's help getting to infusions or to clinic appointments, or even if they have experienced some physical decline and are unable to kind of provide themselves injections at home. Those are all things we need to take into account when deciding a treatment plan for our patients. So how do I choose a medication for my older or frail patient? Principles of medication selection are similar to younger patients with respect to disease presentation and prognosis. And there's little evidence to suggest any age-related differences of efficacy of our patients. The main thing that we would be considering would be safety concerns, which should be considered more prominently in our older patients, including thinking about their comorbidities, and just remembering that safety data is sparse in our older adult populations. As I mentioned before, we need to consider whether a patient is able to self-administer injections as well. The principles of pre-immune modulator and biologic initiation testing are the same in our older adult patients. And really, I think that our principles of medication selection should be guided by considering that therapy should not be delayed or steroid therapy prolonged out of concerns for treatment-associated risks. So what about withdrawal of medications in our older population? Unfortunately, there's been no studies on withdrawal of medications specifically in the older population. However, recent studies of medication withdrawal in general did show that there was no effect of age on prediction of recurrence of disease. Age was not associated with colectomy after withdrawal, and age was not a predictor of infliximab failure after azathioprine cessation as well, if someone started azathioprine and infliximab at the same time. And so these are just some specific points about specific medications that we use. As mentioned before, steroids are more likely to be used as maintenance therapy in our older patients. However, our older patients may already have higher incidence of steroid-related adverse effects, such as hypertension, diabetes, glaucoma, and osteoporosis. Additionally, even psychiatric effects are more common in the older population to begin with, such as anxiety, poor sleep, fatigue, and depression. Budesonide is considered, to have more of a favorable side effect profile, and therefore tends to be preferred over conventional steroids for our older IBD patients. And just to remember that any risk of systemic steroids, really in any patient, but particularly in our older patients, should include plans to mitigate that risk. And then finally, rectal topical steroids are a great choice in lieu of systemic steroids if patient has rectal disease. However, just to remember that they may be poorly tolerated in those that have limited mobility and rectal tone, which might be more common in our older patients. And the foam formulation may be better tolerated in these patients. So I usually preferentially choose the foam formulation. There are 5 ASAs. As we all know, there's a lack of systemic immunosuppressive effect, so these are very attractive. And they are efficacious for induction and maintenance of remission in at least moderate, if not severe UC. However, the efficacy is not established in Crohn's. As we mentioned before, a large proportion of patients with UC, but also Crohn's patients who are older are receiving 5 ASAs, despite the fact that efficacy is not established in Crohn's. And then just to remember that older patients may already have some decline in their renal function, and to be cautious and monitor closely renal function due to the rare but potential adverse effect of interstitial nephritis. With respect to thiopurines, they have a greater likelihood of hepatotoxicity in our older adult patients. However, interestingly, acute pancreatitis is less likely in our older IBD patients. In patients who start the medication greater than age 60, they are more likely to experience myelotoxicity, digestive intolerance, and hepatotoxicity from these medications. And older patients are more likely to experience a thiopurine-related malignancy, such as non-melanoma skin cancer. And lymphoproliferative disorder is more common in our older patients on thiopurines than younger. So what about the anti-TNF agents? There are mixed studies on efficacy in the older population. The one meta-analysis showed no difference in efficacy compared to younger patients. There is an increased risk for treatment-related adverse events in older patients on anti-TNFs, including infections. There were 13% versus 6% rate of infections compared to younger patients. And cancer risk was 3 times that of younger patients on anti-TNFs. And older patients may already have a higher rate of contraindications, for example, congestive heart failure. Finally, greater than 20% of older patients discontinued their therapy within 1 year. However, again, important to remember that the benefit may outweigh the risk in many, and particularly non-frail elderly adults. And so vedolizumab is kind of considered the model drug for an older adult patient, given its lack of systemic immune suppression. However, so far there is some limited data on in the elderly population on safety and efficacy. However, this suggests no difference on efficacy with younger patients and potentially a lower rate of infection versus anti-TNF. And that was demonstrated in this study. So in the anti-TNF group, really very minimal difference between vedolizumab. However, there was an article published in September 2022, which was a comparative effectiveness study comparing safety and efficacy of infliximab to vedolizumab, specifically in older adults with IBD. They followed 754 patients with IBD who were 50 years or older from the Danish National Patient Registry and had a mean follow-up of 32 to 40 weeks. The primary effectiveness outcome in this study was a composite outcome named treatment failure, and defined by IBD-related hospitalization, IBD-related surgery, and new steroid initiation more than 6 weeks after starting the biologic. The overall composite outcome of treatment failure was higher in vedolizumab, but in subgroup analysis, vedolizumab had a 77% increased risk for failure in Crohn's disease. However, no difference for UC. And additionally, in the components of the composite score, there was an overall increased risk for abdominal surgery, as well as hospitalization in the vedolizumab group. There was no, the steroids also had a higher risk of initiation in our Crohn's patient, however, not in UC patients. there was no significant increased risk in infections for any IBD phenotype. So I think this study kind of demonstrates that there are two things that determine a drug's safety and efficacy: overall immune suppressive effect, as well as its efficacy in reducing inflammation and minimizing disease-related infections and complications. And so this study, I think, provides support for using anti-TNF therapy, potentially even first line in our older patients, particularly in Crohn's disease, as there was really no difference in serious infections, and it was actually much more efficacious than vedolizumab in this study. And then moving on to ustekinumab, again, very little data. However, these older patients on ustekinumab in this study were less likely to achieve clinical remission. However, there was no difference in infections or post-surgical infections as well. Unfortunately, there is no specific data quite yet for risankizumab and in the elderly population. However, dermatologic data did not suggest any difference with the younger population. And then lastly, on medications related to JAK inhibitors, there were serious infections comparable with age group with the younger and older patients. We all know that zoster is increased specifically in the older population on JAK inhibitors. Additionally, patients experience an increased rate of malignancy and non-melanoma skin cancer. And I think most of us know about the increased risk of VTE among older patients with cardiovascular risk factors in the RA population. However, thus far, there's been no strong signal for increased VTE and mortality in IBD patients on JAK inhibitors. So how will my patient do with surgery when they need surgery for their IBD? Postoperative mortality at 30 days after surgery is higher in our IBD patients for both Crohn's and UC. Post-op complications and length of stay was also higher, with hospitalization greater than 30 days at 5% versus 1.8% in the younger population. Infections, VTE, bleeding, and cardiac, renal, and neurologic complications were also higher, 34% versus 21%. IPAA surgery in frail and older adults in this study of 2,400 UC patients showed worse functional outcomes in the older population and 0.8 days longer hospital stay for those greater than age 60, so a slightly longer length of stay. Post-op complications were actually pretty comparable in this study between younger and older patients. And even in the frail population in this study showed a similar number of complications and hospital length of stay, however. So the care pathway that we alluded to before states that elderly patients may have increased complications from surgery and poor pouch function. It's important when determining a patient's candidacy for a pouch to consider, however, conditions that predispose to pouch function rather than simply age. So those conditions include obesity, pelvic radiation, and sphincter damage or dysfunction. Additionally, elderly patients may have a harder time with stoma management, but some studies suggest that they have less trouble adjusting to the ileostomy than younger patients. And then finally, in all patients, we don't want to forget perioperative VTE prophylaxis, as well as nutrition assessment and optimization prior to surgery. And so speaking of nutrition and our IBD patients, how does malnutrition impact my patient? Malnutrition is present in 65 to 75% of patients with Crohn's disease, and up to 85% of Crohn's patients who are undergoing surgery have some rate of malnutrition. It is a risk factor for post-op complications and does increase the inpatient length of stay and total cost of hospitalization in patients with malnutrition. So how can we help to reduce the risk of patients with malnutrition preoperatively? So we can use nutrition prehabilitation This means using nutrition interventions to reduce malnutrition and optimize nutritional status prior to surgery. Interventions include either exclusive enteral nutrition or partial enteral nutrition. So that's exclusive enteral, for example, shakes, nutritional shakes, and or partial enteral nutrition, which would be receiving part of your calories from shakes, part of your calorie from whole food diet. Interventions in nutrition prehab also include education. So talking to the patient about the purpose of nutrition prehab, what are these types of nutrition plans, and what is the evidence in improving outcomes after surgery? And then finally, counseling the patient, of course, on strategies on how to implement these diets, as well as how to increase calories and protein from their diet pre-surgery. And what are the benefits of nutrition prehab? Well, nutrition prehab has been shown to reduce 30-day postoperative complications, and that includes all complications, infections, surgical complications, and non-surgical complications. Additionally, 25% of patients treated with exclusive enteral nutrition were actually able to avoid surgery altogether. Patients experienced a shorter surgery time and reduced post-op abscess and anastomotic leak when they underwent nutrition prehab. And a meta-analysis showed reduced rates of wound and intra-abdominal infection. So we'll continue a little bit along the theme of malnutrition and IBD. This is a study that Dr. Memel performed here at our UCSF population, and will be presenting at DDW this year. So we looked at patients with UC who were 65 and older, and we found that 18% of our UC, our older adult UC population, had an 18% rate of malnutrition, and that malnutrition was associated with osteoporosis, fracture, and thrombus development. 75% of this population had at least one vitamin deficiency, including 43% with iron deficiency, 38% with vitamin D deficiency, and 22% with magnesium, and 21% with phosphorus deficiencies. Of note, less than 20% of our patients even had a plasma zinc or vitamin C measured. These are helpful for wound healing, and some data suggest that zinc deficiency is associated with more severe colitis and surgery, and they are recommended to be monitored closely in our IBD patients. 49%, or nearly 50% of our patients did have some type of bone-related disease, 32% with osteopenia, 17% with osteoporosis, and our patients experienced, 14% of our patients experienced a non-traumatic fracture. This is, it's concerning because only 39% of our patients that had prolonged steroid exposure in the past had even had a DEXA scan. And so we likely were under-measuring, under-reporting the rate of bone-related disease in our population. Also, unfortunately, there's no clear consensus from our GI Society guidelines on the age to initiate DEXA screening, or the frequency with which to screen for bone-related disease. And so I think this study shows strong support for working towards a consensus guideline on DEXA screening for our older IBD patients. And there has been some progress on malnutrition guidelines from our GI societies. Just this year in January, the AGA provided a guideline recommending regular screening for malnutrition, as well as vitamin D and iron deficiency in all IBD patients. And the European guidelines published in 2019 recommended weights at every visit and close monitoring for malabsorption parameters, also in all IBD patients. And so moving on just quickly to other healthcare maintenance topics for IBD patients. Older patients have a higher risk of vaccine-preventable illness. However, they still have low rates of obtaining all the recommended vaccines for our older patients with IBD. Elderly onset IBD is not associated with an increased risk of colorectal cancer. However, our patients diagnosed with IBD at an older age may have a shorter interval between IBD diagnosis and a colorectal cancer diagnosis. There's a 3 times risk of missing colorectal cancer in an older IBD patient versus an older non-IBD patient. However, we do need to take into account the increasing risk of adverse events from colonoscopy in our older adult population, such as bleeding, perforation, and cardiovascular and pulmonary events. And so we want to be mindful to apply surveillance techniques to those that it would confer benefit based on life expectancy and those that are healthy enough to undergo the necessary treatment if dysplasia and cancer are identified. So to summarize this presentation, treating older and frail adults with IBD involves careful risk-benefit assessments. Frailty may be a better predictor for health-related outcomes in the IBD population rather than age. However, there's no specific frailty score developed and validated for IBD yet. Multidisciplinary decision-making, of course, is essential in our older population, and colonoscopy is riskier in older patients. Finally, we want to consider increased risk of adverse effects from meds, but also inadequately treated disease in our older population. And always want to put a plug for for monitoring and surveying for vitamin and micronutrient deficiencies, malnutrition, and bone-related disease. And then lastly, we want to maintain vigilance for our healthcare maintenance topics as well. And just want to thank everyone for your attention. Appreciate it.
Thank you, Kendall. That was a really eye-opening talk, especially as our older population with IBD is just growing and growing. There was a question in the chat from Marshall Dower. Do you know if there's any data on mitigating zoster risk with JAK inhibitors with Shingrix vaccination?
Yeah, I don't know the numbers exactly right offhand. However, the Shingrix vaccine does mitigate the risk of zoster in our older patients. Yeah, on JAK inhibitors.
Yeah. Yeah, super important. And